Look at the text on this screen. It poses a specific diagnostic trigger. Would I be surprised if this patient dies within the next 12 months? Within acute care settings, clinicians often assume that answering no to this question implies the withdrawal of active medical management. As this molecular visualization suggests, the transition to terminal care actually requires a shift toward an aggressive, receptor-targeted medical algorithm. In the Netherlands, this precise approach is fully codified in the National Guidelines for Palliative Care, which is maintained by Stichting PZNL. This framework utilizes strict pharmacological parameters, precise neurochemical mapping, and absolute diagnostic criteria. We are going to trace the execution of this protocol from the initial prognostic trigger through targeted symptom control to mandatory postmortem operations. Systematic algorithmic execution provides the clinical framework necessary to address suffering that eludes generalized comfort care. This flowchart outlines the three-phase workflow of proactive Zorg planning, or advanced care planning, which begins with an exploratory dialogue. The clinician must map out specific complications based on the patient's pathology, such as the risk of suffocation in ALS. These pathology-specific risks inform the Behandelgrenzen, the treatment limits. This step establishes explicit, legally binding boundaries on DNR orders, intubation, and ICU admission. To enforce these boundaries, the entire plan is recorded using the Uniform Vastloggen template. This standardized documentation ensures the plan is accessible across all electronic medical records whenever a patient moves from a hospital to a hospice or their home. Simultaneously, the regional general practitioner and out-of-hours services are synced to this file to prevent emergency interventions that would violate the patient's preferences. Standardizing these records creates an administrative firewall that maintains treatment limits during patient handoffs. When symptom management begins, the Dutch protocol utilizes direct anatomical and neurochemical mapping rather than generic relief strategies. Look at this dual-branch logic tree for terminal nausea and vomiting. It requires the clinician to diagnose the underlying pathway before selecting a medication. If we follow the left branch, the trigger is opioid-induced stasis or gastroparesis. The target here is gastrointestinal motility. The first-line intervention is initiating a continuous subcutaneous infusion of metoclopramide to stimulate gut movement. However, metoclopramide must be avoided if the patient has a mechanical bowel obstruction, as forcing motility against a fixed blockage causes severe colic pain. Now look at the right branch. Metabolic crises like uremia bypass the gut entirely, activating the brain's chemical trigger zone. The pharmacological countermeasure targets central dopamine receptors directly with a continuous infusion of haloperidol. If these initial pathways fail, or if a full mechanical obstruction occurs, the protocol moves to a final escalation step. This utilizes levomepramazine for broad-spectrum receptor antagonism, combined with octreotide to halt the production of gastrointestinal fluids. Selecting medications based on receptor affinity increases the probability of resolving symptoms that have resisted first-line interventions. During the final 72 hours of life, the objective transitions entirely to the quality of dying. This checklist highlights the necessity of demedicalization. In this phase, standard life-prolonging interventions frequently generate iatrogenic harm and must be stopped. Artificial hydration is particularly problematic. Continuing IV fluids in the dying phase can lead directly to the development of the death rattle. As seen here, artificial fluids drive the hypersecretion of salivary and bronchial liquids. As the swallowing reflex fails, these fluids pool in the hypopharynx. The protocol responds by stopping all hydration and administering continuous scopolamine butylbromide to prevent the formation of new secretions. For patients at high risk of a catastrophic vascular rupture, the guidelines mandate a crisis box be placed directly at the bedside. In the event of a carotid eruption, the protocol requires environmental modifications, such as using dark green towels to absorb blood and minimize visual distress for the family. The moment a rupture occurs, the team delivers a crisis bolus of midazolam and morphine. This bolus induces rapid unconsciousness and respiratory suppression, ensuring the patient remains asleep through the risk of asphyxiation. True demedicalization is an active, aggressive clinical posture designed to protect the dying physiology from the trauma of standard acute care. When severe symptoms are declared refractory by a specialized team, the protocol allows for palliative sedation or palliative sedation. Under Dutch law, continuous sedation is reserved for patients with an estimated life expectancy of 14 days or less. This titration ladder begins with a first-line continuous subcutaneous infusion of midazolam. To manage breakthrough distress, the continuous rate is permanently increased by 30 to 50%. The protocol establishes a pharmacological ceiling for this medication at 8.4 milligrams per hour. If distress remains refractory at this limit, Step 3 adds the neuroleptic levomepramozine to the infusion, oral anesthesia using propofol. Meticulous titration ensures that the level of sedation remains proportional to the patient's distress, following strict pharmacological limits. The clinical protocol continues after death is pronounced, branching into 3 distinct post-mortem phases. Phase 1 requires granting unhurried bedside space to honor the physical and cultural dignity of the deceased. Phase 2 mandates a structured debrief for the clinical team using the CURA framework, which helps identify secondary traumatic stress in healthcare workers. Phase 3 involves a structured aftercare consultation with the family, exactly 6 weeks post-mortem. During this meeting, the primary physician screens the family for prolonged grief disorder based on ICD-11 parameters. This screening allows for systematized referrals to psychological services, concluding the family's care trajectory. High-quality palliative care relies on the fusion of human empathy with uncompromising, data-driven execution. Systematizing this process provides the most reliable path toward patient comfort.
Palliative pain management is often perceived as subjective intuition. In practice, the protocol functions as a precise, linear pharmacological algorithm. This algorithm is governed by the official national databases of PalliaWeb and Stichting PZNL, providing the clinical-grade framework for narcotics titration. Under these protocols, every pharmacological action is strictly dictated by the mathematical input of an initial assessment score. For cognitively competent patients, clinical comfort is defined by the numeric rating scale. The protocol targets an NRS score of 3 or lower as the gold standard for analgesic success. If a patient cannot self-report due to cognitive impairment, clinicians are required to use observational scoring tools like the PAIC-15 or RITA scale. These essential assessments must be administered at least twice daily to actively monitor facial expressions and behavioral resistance during routine care. This precise measurement is the non-negotiable input required to trigger the pharmacological escalations that follow. The traditional World Health Organization 3-step pain ladder has long served as the historical standard. However, modern Dutch guidelines now provide a critical revision, the total bypass of Step 2. For patients with advanced incurable diseases, clinicians are directed to move directly from non-opioid medications to low-dose strong narcotics. This bypass is clinically justified by the unpredictable pharmacokinetic ceiling of weak opioids like tramadol, which often cause gastrointestinal toxicity without providing predictable analgesia. The Step 1 foundation remains fixed. Paracetamol is limited to a strict ceiling of 4 grams per 24 hours, with immediate reductions to 2.5 grams for frail patients weighing under 50 kilograms. If the clinician utilizes NSAIDs, the protocol requires a co-prescription of 20 milligrams of omeprazole daily for gastric protection. Eliminating the middle step prevents the risk of prolonged, ineffective dosing and allows for the linear titration of strong opioids. When initiating strong opioids for an opioid-naive patient, the protocol sets specific baseline parameters. Orally, this starts with prolonged-release oxycodone at 5 to 10 milligrams, or morphine at 10 to 20 milligrams every 12 hours. If the patient is unable to swallow, clinicians transition to a continuous subcutaneous infusion using a syringe driver to deliver 20 to 30 milligrams of morphine over a 24-hour period. To manage sudden spikes in pain, the baseline must be paired with an immediate-release breakthrough dose available every 4 hours. The protocol enforces a fixed clinical ratio. The breakthrough dose must be exactly 1/6 of the calculated 24-hour baseline total. This ratio ensures that as the 24-hour baseline is escalated, the breakthrough analgesia remains proportionally potent and safe. Factors like worsening renal clearance or severe neurotoxicity eventually necessitate an opioid rotation, switching the patient from one narcotic to another. This process requires a strict 4-step mathematical workflow to prevent the risk of a fatal overdose during the transition.
Step 1 is the calculation of the true 24-hour total. This is the sum of the baseline dose and every breakthrough dose consumed over the previous day. Step 2 utilizes the core matrix to determine the equi-analgesic dose of the new narcotic. For example, 60 milligrams of oral morphine converts to a 25 microgram per hour fentanyl patch. However, clinicians must account for incomplete cross-tolerance. Receptors may be more sensitive than the raw conversion suggests. Step 3 is the mandatory safety reduction. The clinician must reduce the newly calculated dose by 25 to 30%. This safety reduction is only omitted if the rotation is being performed specifically to address severe, uncontrolled pain. In Step 4, the clinician recalculates the new immediate-release breakthrough dose based on this adjusted 24-hour total. This equi-analgesic matrix allows clinicians to manage toxicity while protecting the patient's respiratory stability during the transition. A prescription for a strong opioid is considered medically invalid unless paired with proactive side effect prophylaxis. Opioids bind to mu receptors in the enteric nervous system, stopping peristalsis and causing opioid-induced constipation. The body never develops a tolerance to this. The protocol requires a dual-action prophylaxis on day 1, an osmotic laxative like macrogol, and a stimulant laxative like senicides. For refractory cases, clinicians use a PAMORA like methylnaltrexone. This agent neutralizes peripheral receptors in the gut without crossing the blood-brain barrier, restoring bowel function without interfering with central pain relief. Nausea and vomiting are driven by dopamine receptor stimulation in the brainstem's chemoreceptor trigger zone. This symptom is typically self-limiting, resolving within 3 to 7 days as the body builds tolerance, but can be managed with metoclopramide or haloperidol in the interim. More severe is opioid-induced neurotoxicity, where the accumulation of active metabolites leads to myoclonus, confusion, and hallucinations, requiring immediate rotation and hydration. The active receptor-level manipulation of these side effects is as critical to the patient's stability as the analgesia itself. In palliative care, a mild slowing of the respiratory rate is an expected pharmacological effect. If the patient is comfortable, no intervention is required. If an accidental overdose causes acute distress, administering a standard bolus of naloxone is cataclysmic. It will instantly strip all central analgesia, throwing the patient into severe acute withdrawal and pain. The emergency protocol requires fractional dilution. 1.4 milligram ampule of naloxone is mixed with 9 milliliters of normal saline to create a concentration of 0.04 milligrams per milliliter. Clinicians administer this solution in microdoses of 1 to 2 milliliters every 2 to 3 minutes. This administration stops the moment the respiratory rate rises above 8 to 10 breaths per minute. This carefully resolves the distress while leaving the patient's baseline pain control intact. Mastering this mathematically sound pharmacology provides the tools required to engineer and protect clinical comfort until the end. With intravenous opioids, we rely on the circulatory system for pain relief. But as doses escalate, the smooth delivery mechanism becomes violently turbulent and chaotic. In advanced palliative care, severe visceral pain syndromes eventually reach a threshold where they are completely refractory to high-dose systemic narcotics. This graph illustrates the clinical reality of escalating dosage. The analgesia curve flatlines early, while the toxicity curve spikes exponentially. Pushing more drugs into the bloodstream at this point triggers severe neurotoxicity and terminal delirium without providing further relief. Hitting this wall requires a shift away from the bloodstream, moving toward targeted architectural interventions directly within the central nervous system. One option is permanent chemical neurolysis, which intentionally destroys the pain pathway via Wallerian degeneration. The second option is continuous neuraxial microdosing, which bypasses the blood-brain barrier entirely. In these terminal stages, pain management is an exercise in applied fluid dynamics and spatial physics within the architecture of the spinal canal. While phenol and ethanol both achieve nerve destruction, their distinct chemical behaviors dictate completely different injection protocols. Dehydrated ethanol is hypobaric and typically 50 to 100% concentrated. Its low viscosity diffuses rapidly, causing severe burning pain requiring pre-injection anesthetic. Conversely, phenol is 6 to 10% concentrated. Mixed with glycerin, it becomes hyperbaric and acts as a painless local anesthetic. These physical traits dictate their use. Ethanol's rapid diffusion is ideal for celiac plexus neurolysis, treating refractory abdominal pain from pancreatic or gastric malignancies. A successful CPN block triggers a sympathetic blockade, which often causes post-procedural diarrhea and transient orthostatic hypotension. In practice, clinicians utilize phenol for targeted peripheral blocks, like the PENG block for frail geriatric hip fractures. This reduces systemic opioid requirements in patients who are candidates for non-operative management. A temporary diagnostic block with lidocaine must always precede a permanent neurolytic injection. This confirms the procedure yields satisfactory pain relief without inducing unacceptable motor paralysis. Clinicians select a neurolytic agent based on how its specific viscosity and baricity allow them to physically control its spread through the patient's anatomy. We use the S-PENG block to treat severe unilateral pelvic cancer pain or localized bone pain in terminal patients. Phenol and glycerin is hyperbaric, sinking in cerebrospinal fluid. The patient is positioned laterally, painful side down, and tilted backward 45 degrees. This angle ensures the phenol safely bathes the lower dorsal sensory roots while sparing the upper ventral motor roots. Gravity acts as the surgical scalpel in this procedure, allowing for the permanent destruction of pain signals without paralyzing the patient. If a peripheral nerve is only partially ablated, the patient can develop deafferentation pain, a form of severe, intractable neuropathic pain. When neurolysis carries too high a risk of motor loss or deafferentation pain, the definitive pathway shifts to neuroaxial drug delivery. Placing medications directly into the central nervous system achieves exceptional localized analgesia at a fraction of the systemic dose. Hardware choice is dictated by life expectancy. For a prognosis of weeks to 3 months, we use a percutaneous, tunneled catheter with an external pump. For survival beyond 3 months, we utilize a fully implanted intrathecal drug delivery system surgically placed in the abdomen. Hardware selection aligns the physical engineering of the device with the patient's remaining time. Once the hardware is in place, the spread of the medication inside the spinal fluid depends on its lipophilicity. Hydrophilic morphine spreads widely up and down the spinal canal, ideal for treating diffuse pain. Lipophilic fentanyl binds rapidly and tightly near the catheter tip, preferred for highly localized pelvic or unilateral pain. To enhance relief, we add local anesthetics like bupivacaine to block sodium channels on the nerve roots. Bupivacaine requires careful daily titration to prevent motor block, leg weakness, or orthostatic hypotension. A third adjuvant, the alpha-2 agonist clonidine, is added to enhance inhibition for refractory neuropathic pain. Clinicians stack these chemical mechanisms to create a profound local blockade that systemic delivery cannot match. Bypassing the blood-brain barrier achieves profound localized analgesia, but it simultaneously strips away the body's natural safety margins. All medications introduced into the epidural or intrathecal space must be strictly preservative-free. Standard preservatives like benzyl alcohol are neurotoxic to the spinal cord and can cause irreversible chemical arachnoiditis or paralysis. Clinicians must also prepare for local anesthetic systemic toxicity, or LAST. LAST occurs if the catheter migrates into a blood vessel. The patient will present with tinnitus, perioral numbness, and profound bradycardia. The emergency protocol requires immediately clamping the line and administering 20% intralipid, an intravenous lipid emulsion, to neutralize the systemic local anesthetics. Because the body's natural filters are bypassed, toxicity happens instantly, requiring immediate biochemical neutralization. We must monitor for acute catheter migration in either direction. Outward migration causes fluid leakage at the dressing and a sudden return of baseline pain as medication fails to reach the spine. Inward migration results in a massive overdose, causing profound respiratory depression. In the event of inward migration, clinicians stop the pump and administer diluted ultra-low-dose naloxone to protect the airway without triggering full withdrawal. The final emergency is an epidural or spinal abscess. This presents as localized back pain, fever, and neurological dysfunction, requiring emergent MRI and surgical decompression. Advanced interventional palliative care provides a definitive pathway for patients with refractory pain, provided clinicians master both the physical chemistry of spatial pharmacology and the uncompromising rigor of procedural safety.